Thank you very much. Good morning, everyone. And I even understood a little bit about the introduction. But first of all, grazie, Mario. Merci beaucoup pour l'invitation, Nicolas. I'm very honored to be here, and it's a pleasure to talk about shoulder instability in the sporting shoulder. And I want to focus specifically on some challenges for non-operative treatment. Okay, now I have to fix how it works. Okay, so traditionally, shoulder instability is classified into three categories based on the etiology and the direction of the instability. And all three kinds have an acronym, the TUPS, the AOS, and the Ambry. A TUPS patient is a patient who has recently or previously experienced a dislocation, most of the time based on a traumatic event, and it's a unidirectional instability, most of the time in anterior direction. And some sports are more prone to these dislocations than others. Now, because of the traumatic event, there most of the time is a structural injury, which is a Bankert lesion, which is a lesion of the antero-inferior capsulolabral complex, but also the glenoid may be fractured at that space, and then we call it a bony Bankert lesion. Now, the problem with traumatic dislocations is the high recurrence rate. And according to recent systematic review, the recurrence rate varies between 20% and 88%, depending on the study, with many risk factors that have been highlighted. And one of the major risk factors is the age of the patient. This is very simple and maybe a rather old study, but I often use it to explain my patients the risk for a re-injury or not. If you are younger than 20 years old, you are likely to redislocate within the first year at a level of 80%. Now, we don't say that in the first place to our patients, but I tell them that when they come back after a redislocation to seek for more help. So recently, there was a very interesting study from Margie Oles in New Zealand, and she looked at risk factors for recurrence in rugby players. And actually, her recurrence rate is also depending on the age, but was slightly lower than the previous study. It's 50% in the younger age group, and indeed, the recurrence rate decreases with age. But besides age, she also highlighted on other risk factors for redislocation, and the most important one was a bony Bankert lesion. So if you have knowledge of a fracture of the glenoid, this is a high risk factor for recurrence rate of dislocations. She also found that no immobilization increases the risk for recurrence, higher activity levels, and then some psychosocial factors like higher levels of pain and disability, higher levels of fear of re-injury, and decreased quality of life. So these all are things that we have to take into account when we see a patient after a first-time acute dislocation. Now, traditionally, the rehabilitation after a shoulder dislocation occurs in three stages. First, we have the initial phase, where we have to protect the structures that are injured. We have to focus on pain management. We have to focus on adequate motor control and balanced muscle recruitment of the rotator cuff. And then we go to the advanced phase, where we increase the load, we focus on performance, and we prepare the athlete to return to play. And then finally, we have the return to play phase, in which the big question is, which criteria should we use to decide whether the athlete is ready to go back on the field, that combined with high performance exercises. And I'm sure that when the postoperative treatment is discussed, these three phases will be part of the talk. So the only thing I want to focus just shortly is how can we focus on recruitment of the rotator cuff. Now, 2 years ago, there was a very nice systematic review in which they looked at all EMG studies highlighting the activity of the rotator cuff during exercises. And for each of the cuff muscles, they also ranked the exercises based on low activity, moderate activity, and high activity. So when we want to focus on the rotator cuff activity, we mainly want to look at the last category. Now, the main message here is that the best exercises to train the rotator cuff are not always the traditional rotator cuff exercises, like you see in this movie, the traditional full can exercise and the external rotation in a neutral position. But what was also found in this study is that movements like horizontal abduction with external rotation and elevation in a higher angle also highly activate the rotator cuff on the same level as the previous exercises. Now, the movies here are performed in a prone position because that was performed in the studies that were highlighting these movements. But of course, if you do them in a standing position, which is much more functional, you highly activate the cuff as high as you do external rotation. And I think this was was also one of the messages from Jeremy earlier. So in this systematic review, the highest load was found during the push-up plus exercise, which was a little bit surprising, but it highlights the fact that the cuff is activated when it's challenged. You need a lot of shoulder stability to do the exercise. So don't always focus on isolated exercises, but go to more functional movements when you want to load the rotator cuff. So a second kind of instability, which is very important in the population this day is the AOS patients, acquired instability overstress syndrome. This is the instability that is the result of frequent overhead throwing, of which at the end the athlete develops a subtle instability due to continuous stretching of the anterior capsule. Now, the problem in AOS patients is actually a little bit double. On one hand, they have a more laxity in their anterior capsule, but we also know that they develop some stiffness in the posterior part of the shoulder. So that leads to an imbalance in the hammock principle. So let's suppose that you are at ease in a hammock. What is the chance that you fall out? Well, you fall out of the hammock if one side has no tension enough, and if the other side becomes stiff, and that's exactly what happens in the overhead athlete. So based on this principle, we don't only give exercises to strengthen the shoulder, but we also get advised to do a lot of stretching. And the stretching of the posterior shoulder, when you look into literature, but also in the clinic, we have 3 types of stretches. We have variations of the sleeper stretch performed by the patient or by the therapists. We have variations of the cross-body stretch, also performed by the patient himself or by the therapist, and we can do some dorsal glide translational mobilizations, all to stretch the posterior part of the shoulder. But then the question is GERD so important in that population? Is GERD really a risk factor for throwing-related shoulder pain? Well, as a matter of fact, there is no consensus at all about that, because when we look at this systematic review, you see that some studies indeed say that people with GERD are prone to more injury, but there are studies that show even the opposite, that GERD would be protective against injury, and there is no consensus to say that GERD is indeed a risk factor. And as mentioned before, Martin also wrote a very good systematic review showing that the most important risk factors for shoulder pain are the non-modifiable, like gender and age. So then maybe we are looking at the wrong variable here. We are looking at the wrong structure, because the big question is, and I'll explain the parachute in a minute, why is the posterior shoulder becoming stiff? Well, we call it a normal adaptation to frequent throwing, where you have to decelerate your arm, and the posterior shoulder becomes stiff as an adaptation. But actually, if we downsize it a little bit to the level of the capsule, is it the role of the capsule to decelerate the arm? No, it's the role of the muscles. So maybe the posterior shoulder becomes stiff because the muscles are not strong enough. In particular, the deceleration capacity of our external rotator components. So maybe we should focus much more on external rotation strengthening than stretching of the posterior shoulder. Because indeed also here there is no 100% consensus, but we know that consistently strength deficits in the external rotators are considered to be risk factors for throwing-related shoulder pain. We also know in elite overhead athletes that there are some early structural adaptations. For instance, in a German study, there were some cystic changes in the posterior cuff, and we also found in elite adolescent tennis players that they had early signs of tendinosis. Now, to make sure they had no symptoms, but maybe we can consider this as a small ticking time bomb. We don't know at the end what will happen. And a third issue has nothing to do with sports, but we did a study in which we experimentally induced pain in the supraspinatus, and we looked at what happened in the other muscles. And the muscle that reacted the most with inhibition of activity was the infraspinatus. So maybe our posterior cuff is also prone to inhibition as a result of pain. And all these 3 things together tell us, well, training the external rotators in their deceleration capacity is an important treatment goal. So am I saying now that we should ignore GERD in our treatment in view of the treatable, the transport treatable aspects? No, I don't think so, because we do have some arguments to do stretching or to train to improve mobility into internal rotation when someone has symptoms. As an example, Tim Tyler from the US, he showed that there was a resolution of symptoms after treatment of GERD, and that was associated with increased range of motion. So there was an association between less symptoms and more range of motion. We also did a study a year later in which we showed that stretching in symptomatic subjects with GERD did not only increase range of motion, but also decrease the symptoms measured with a VAS. And then finally, not performed on athletes, no, not performed on symptomatic athletes. One of my colleagues, Annelies Maanout, she found that when you do the sleeper stretch in a healthy population, after 12 weeks, there was not only an increased range of motion, but also an increase in the acromial-humeral distance. So that could explain why stretching in symptomatic patients would work. So I think as a take-home message for that part, if you have a patient with shoulder pain and he has a decreased range of motion, do some exercises, whether it's passive or active, to improve range of motion into internal rotation. So the third group are the Umbra patients. Umbra is atraumatic multidirectional instability, often based on bilateral or even hyperlaxity, generalized hyperlaxity. These patients sometimes can perform this subluxation themselves, and to make sure that I'm not a bad therapist here, I only asked to do this once to the patient, and this movie is repeating himself. So this is a totally different population. And in some sports, like in swimming and gymnastics, in circus artists, there is a lot of people who need some laxity to perform well. So they're all constantly balancing between instability and performance. Now, when we look at the general guidelines for the treatment of multidirectional instability, we are told to improve local deltoid control and provide sufficient superior humeral head translation, because all these patients have a humeral head that is too much inferiorly. We should focus on scapular upward rotation, because most of them have too much downward rotation. We can, for the safety of the patient, start with low-load closed chain exercises, and low-load mean not too much body weight on it, but enough to have some approximation in the joint. And we should provide approximation in the joint during open chain exercises. And then the question is, how can we do that? So with respect to the local deltoid control, oh, I need no noise on this one, please. No noise. Thank you. Because this is really live research, right? So we did a study, and I only took some anecdotal data to show you what we did. The exercise we performed was pushing the hand downwards, like you see on the left picture. It's a low-load closed chain exercise, because you just push your hand downwards. And what we found to start with is, as soon as you push your hand into a ball, you have increase in middle deltoid activity. And also the anterior and the posterior deltoid start to work even without moving. So it actually tells me that when you push your hand down, you activate the deltoid, and that's the muscle that they need to work on to have some superior migration. We also looked, not at the same time, of course, because it's not possible from a technical perspective, but we also looked with ultrasound at the acromial-humeral distance. And what we found, but this was in patients with extreme shoulder instability, no athletes. That was a study on Ehlers-Danlos patients. But we found that if you give them a dumbbell of 2 kilograms, there is a significant increase in the acromial-humeral distance. So don't give them dumbbells, because they're already in a bad position. But if you close the chain, like in this exercise, we had a decrease of the acromial-humeral distance, suggesting that maybe there is a superior migration of the humeral head. The second thing is focus on scapular upward rotation. You see on the movie on the left, which is also anecdotal data from the study on the Ehlers-Danlos patients, that many of these patients have too much downward rotation during elevation of the arm. And we can see that here, but I'll give you a graph a bit later. And this is really something that I think all of you recognize also in the practice in a subpopulation of your patients. So in our treatment, we should induce scapular upward rotation. And what is the easiest way to do that? Can you start the movie, please? It's by adding a shrugging to a movement. For instance, this patient is elevating her arm. She's limited, but when I allow her to perform a shrugging, she has full elevation. The same now, I ask her, can you touch the back of your head? And she does that with limitation, but if I allow her to add a shrug, which is upward rotation, she gets full range. So indeed, in this patient population of atraumatic multidirectional instability, adding shrugging to exercises may be a good idea. Not always like this, but maybe in higher elevation angles. Okay, so because in our recent study, we used a special way to analyze the EMG results, and we found that when they elevate their arm in the beginning and at the end of the movement, they really have this more downward rotated position. This is also the moment that you can, if you wish, use some elastic tape. Now I'm being the clinician, the head of the researcher goes up and the clinician goes on. What I often do is I put some tape, the pink ones are actually to help the deltoid in superior migration, and the blue one is actually performed in a shrugged position, so they have a feeling the shoulder is more supported. And without having any evidence on that, the reaction of the patient is very often that it feels much more comfortable. So we have to start with closed chain exercises, and what I mean with low load closed chain exercises are these ones, bench slides or wall slides. And we did an EMG study on a progression, starting with bilateral bench slides, so it's the lowest level exercise, and ending with wall slide against an extra resistance, and we looked at a number of muscles. And what we found was an increasing activity in the anterior deltoid, which is good because that's what we want, and also increasing activity in the four scapular muscles that we measured. And maybe not the topic of today, but I don't know if I have a light here. This one. As you can see, the infraspinatus, which was in that study, the marker of the rotator cuff, remained rather inactive throughout the exercise progression. Okay, the last one between the Umbra patients, if we want to do open chain exercises, it's better not to give them a dumbbell in the hand and to do this, because you have inferior translation of the humeral head, and on top of that, you have shear forces in the joint. It's better to do exercises that somehow give a compression in the joint. It feels safer and probably also gives a better motor control. So last but not least, we all know, or we all are convinced from a clinical perspective, that we should implement a kinetic chain. And we also have a lot of clinical papers highlighting that topic. But the question is, what is the real value of kinetic chain exercises? Is it really working? Well, it depends on what question you ask. If you ask, can we change muscle recruitments by implementing the kinetic chain? The answer is yes, we can, because we have a number of studies confirming that. As an example, when you perform diagonal patterns, you increase scapular muscle activity in total. When you challenge core stability, for instance, by performing a planked position or a side plank position during your shoulder exercises, you mainly increase serratus anterior activity. And trunk rotation increases trapezius activity. So we do have some arguments to implement functional kinetic chain components into our exercises. But is our patient getting better because of this? Well, so can we change the treatment outcome with the kinetic chain implementation? Now, the results are preliminary because it's only a pilot study, but we think we don't. We recently did a study in overhead athletes with mild aspecific shoulder pain, throwing-related shoulder pain, and we divided them into 3 treatment groups. The first group only did shoulder exercises. The second group did shoulder exercises and, in addition, some lower extremity and trunk exercises, not involving the shoulder. And the third group did integrated exercises. So instead of doing an exercise like this, they had to do it combined with a squat. And the question was, did they get better? Well, they all got better because there was a significant improvement after 6 weeks training, but there was no group differences based on the classification, implementation or not of the kinetic chain. So what is the message for the clinician? Should we skip all kinetic chain involvement? No, of course not. Because to start with, it's much more fun. It's much more fun for an athlete to do exercises in which his whole body is involved. And this was something we had as a feedback, a qualitative feedback of the third group, the group that did indeed implement the exercises. They had a good time management because they trained the both sides at the same time. And they also said it was much more challenging. And also, when you do kinetic chain implementation, you can address the kinetic chain deficits that you have found in your clinical exam. So to end up with, I want to thank you all for coming, and I want to thank all the members of my team for giving them the opportunity to present their work. Thank you very much.
Thank you very much, Anne. I don't know if you can see the question which are liked, but I have it. The question from the audience would be, what is your favorite rotator cuff activation exercise, Anne?
Oh. How long can I think about that? Well,
60 seconds.
Yeah, definitely. It depends on the stage your patient is in during his rehab. And within the stage, I don't mean time-based stage, I mean the level of irritability. If you have high irritability, you have to choose sometimes a more isolated exercise. And if you have low irritability, you choose more functional exercises. And since we know that as soon as you implement external rotation into a movement, your external rotators will be activated, and I have I'm a little bit more in love with the external rotation side than the internal rotation side. I think an exercise like the WV with a resistance coming from there is a very good one, because you do the elevation and you constantly get your external rotation activation. So the more functional, the better.
Thank you very much.